Right, so I'm going to talk about allergy. And allergy affects all ages, and when you talk to the general public about allergy, they'll think about children. Obviously, I'm in an adult clinic, and I see all adults, including going up into old age, and we've had new presentations in people in their 80s. This is Barbie. She's a baby boomer. She was born in the late 50s. And it was imagined for her 50th birthday what she was going to look like. I don't think she'd have gone with grey, actually. I think she'd have gone with plastics and hair dye. But the poem, the Longfellow poem, is really about the fact that as we get older, the metaphor is that allergic disease is actually much the same as you get older, but the landscape changes. I quite like, this is quite comforting because you think, well, as I get older, the landscape's different, but it's just as beautiful because I get the stars as I get older, and grey hairs and whatever. So allergic disease in adulthood has much in common with childhood disease. The epidemiology is different. It's not always recognised, and it's not even considered in some cases. As you get older, you do develop other medical conditions which might require treatment, and their use may influence the presentation of symptoms or even the severity of disease. And what I'm going to say is that I think the access to adult care for patients with allergic disease is falling behind that for paediatric age group. And I don't see light at the end of the tunnel on that. I'm quickly going to talk about primary and secondary food allergy, just so that you understand some of my slides. So primary food allergy is when you're sensitised to the actual food stuff, egg, milk, peanuts, tree nuts, whatever. And the route of the sensitisation is thought to be through the gut or the skin. And it's commonest in patients with atopic disease. So they might have coexistent eczema, asthma, allergic rhinitis, but it may occur without. It's quite interesting in adult clinics. You see people who have no other food, no other history of allergic disease, who present with an allergy to a single foodstuff, often presenting sort of in the 40s and 50s. Primary food allergy may resolve if it develops in childhood. I don't see that happening when it presents in adult life. Secondary food allergies, when patients are sensitised to pollens. There are cross-reactive proteins in pollens that turn up in foods that are plant-derived, such as fruit, vegetables and nuts, and patients get allergic symptoms when they eat those cross-reactive fruits. And the commonest one in the UK probably used to be called birch oral allergy syndrome. We now refer to it as pollen food syndrome. And they have springtime hay fever because that's when birch trees pollinate, and they have an itchy mouth if they eat apples, pears, cherries, if they eat almonds, walnuts. But there are other pollens that have cross-reactive allergens. Mugwort, which is a weed, cross-reacts with celery, carrot and spices, and there's the mugwort celery spice syndrome, and ragweed. Ragweed is a weed, as the name implies, and it used to be a big thing in the eastern seaboard of the States, really, and I went to a pollen conference in 2004 in Worcester, which has a big centre, and they said, oh, we're beginning to see ragweed in the south of the UK. And now we've started skin testing patients, and we're seeing ragweed sensitisation in patients in the Midlands. So it's progressively moving northwards, and that reflects, I think, global climate change. The birch pollen season has certainly changed with global climate change. So the epidemiology of adult-onset food allergy, well, first thing to say, there's actually very little data. There's quite a lot of data in paediatrics, very little done in 18 plus. There's a European prevalence study. They looked at 6 centres, 20 to 54-year-olds, and it varied from centre to centre, the minimum being 6.6% and the maximum being 23.6%. But what made the difference when they looked at what people were actually allergic to was their secondary food allergy. So it reflected the pollen sensitisation and the food reactions that people have because they're allergic to pollen. There's a US study, they looked at case notes, and the age of first reaction in the 171 patients ranged from 18 to 86. As you're older, you're much more likely to go to the ER for emergency treatment, and you're much more likely to require adrenaline. And this is just looking at electronic patient records. It's a Spanish study, and they're looking by age group about reported allergies, and you see drug allergy increases with age, whereas food allergy seems to decrease. Venom allergy, we've had quite a lot about food today, and what I would say is that the stuff that's been presented about the sort of principles of food allergy in childhood, applies to that in adult life. I was going to talk about other allergies. From venom allergy, we've got patients who are allergic in the UK to bee and wasp venom, and it accounts for 5 deaths per annum approximately, anaphylaxis with them. The sensitization rates vary in adults, but they're much higher than they are in children. I think there were 2 studies in children, US Scouts, who I'm assuming that they have an outdoor life, and Italian children in a rural setting. So much higher sensitization rates. And the risk factors for being venom allergic is occupational exposure. So roofers get it, gardeners get wasp venom allergy, or hobby related. And beekeepers are they love their hives. They'll carry on getting stings, and they'll carry on looking after their hives despite getting allergic symptoms. Venom allergy isn't associated with atopic disease. Overall, the mortality rate is low, but it does increase with age, and that's thought to be due to the fact that as you get older, you have less cardiac reserve, and you may be taking beta blockers. So I'm going to move on to my first history. This is a chap who was referred to me about 8 years ago, 82-year-old, and he was staying on the Norfolk coast, and he'd had lunch at Cromer, and he'd eaten Cromer crab, and he'd driven himself and his dining companion back to the Blakeney Point Hotel. And he collapsed in the foyer whilst walking back to his room. And there was a GP lunchtime meeting. So he was immediately jumped upon by many GPs who resuscitated him. And he didn't end up going to hospital, actually, which is quite good, because the nearest hospital is some considerable distance away. But they did note that he was in atrial fibrillation. So he came back to his GP, who said, right, well, we'll send you back to a cardiologist. You collapsed because you're in atrial fibrillation. He was generally very well for an 82-year-old, lived between the UK and his son's house on the Normandy coast, where he would spend months living, eating copious amounts of seafood and shellfish. He was on Proscar, which is benign prostatic enlargement, and he had no history of any allergic problems or atopic disease at all. He was seen by a consultant cardiologist who said, yes, you are in atrial fibrillation. And they prescribed him beta blockers because they felt that the rate was a little bit high, and that wasn't good for him. But the patient went to the cardiologist, but could this be crab allergy? Because my arms were itching on the way back from Cromer to Blakeney Point. Could this be allergy? And the cardiologist said, no, don't go, don't worry, go and eat all the crab you want. So the patient goes back to his GP and says, I'd quite like to see an allergist now, because I still think that I might be crab allergic. And he had skin testing, and he was evidence of sensitization, so positive skin prick tests. So he has a history of collapse after eating crab. It was within 60 minutes, and he has supportive skin prick tests. So it's quite unusual to have allergic disease present so late in life, and I suppose the definitive way of proving it would have go on to an open food challenge. However, much to the allergist's relief, he said, no, it's okay, I'll just avoid these things. He was prescribed an adrenaline auto-injector, and he was referred back to the cardiologist because he said, do you really need a beta blocker? Because beta blockers antagonise the effects of adrenaline. So make it less effective when it's used, but they also, for patients who are actually, when you make a pathophysiological response to anaphylaxis, one of the first things you do is try and increase your heart rate to maintain your blood pressure. And the beta blocker, the whole point of the beta blocker is to stop that from happening. So this is something that is increasingly an issue as you get older. So medical conditions may accumulate in adulthood. They might affect your ability to avoid allergens. They might affect your pathophysiological response to anaphylaxis and the treatment that we give for it. So things that can affect the recognition of food triggers or early symptoms of reactions. And so this is when we're seeing patients, you can't just say, well, you need to avoid these. You need to think, how will they avoid those? So visual or hearing loss. I can no longer read the labels of things that patients bring into me. I have a special pair of glasses. And I have become my mother. It's every daughter's destiny, isn't it? And their son's tragedy that they don't. But that's an issue about reading labels. Neurological disease, do people comprehend what you're telling them? Psychiatric disease, I've got adult patients who are depressed and actually can't be bothered to look at their labels. So and part of their dietary restriction is feeding into their depression. Substance abuse, we've got patients who have had accidental exposure where they've been intoxicated by recreational drugs. And medications, I mean, chlorphenamine sedates people to the point where they can't cerebrate from time to time. You think you're giving it for their allergic disease, and actually they can't function on it. And alcohol. This is the predicted cases of late onset dementia in the UK by age group for the next 30 plus years. So it's going to go up. And one of the things about dementia is that you remember things in two sort of broad categories. You remember facts and you remember feelings. And as you dement, you lose your factual information, but your feeling information is relatively prolonged. Is this going to impact allergen avoidance for patients who we're diagnosing now, who are dementing? How do we future-proof advice to keep patients safe? Because we have had patients presenting in the adult clinic who have got early-stage dementia, including a patient who was allergic to celery. Celery is everywhere in all processed food. And we had huge problems explaining to him how to keep safe and that he needed to read labels. I think this is a time bomb. But how do we future-proof advice? Do we just get people so fearful that they remember it? Well, that's not very productive, is it? So I'm open to all comments. Alcohol. Intoxication increases the risk of accidental exposure. And if I could have a tenner for every Leicester student who had been admitted and then come under my care because they had got lashed and then gone home and just eaten anything in the fridge, I would be a rich woman. Alcohol seems to affect the way that we absorb food, and it reduces the threshold, the dose of allergen you need to have a reaction. So in the condition that's already been mentioned, this sort of food-dependent exercise-induced anaphylaxis, where you can have a food without exercise and be fine, but if you have that food plus exercise, you have anaphylaxis. We have seen patients where alcohol seems to have been taking the role of the exercise. We caution patients quite carefully about that when they have food-dependent exercise-induced anaphylaxis, but it may be making a difference just from day to day. There's, you have more reactions when you go out to restaurants, and so you ask patients, and I've had a glass of red wine and I had this meal, and I think it makes a difference. There's less cardiovascular reserve as you get older, so your heart is less good as a pump. So if you have anaphylaxis, it's less able to make all the pathophysiological corrections that you need. And that translates into more A&E attendances. And so it's due in part to ischemic heart disease, coronary artery disease, but also to having hypertension, which makes your heart stiff and less good as a pump. But also the medications that are used for those conditions make a difference. I put this slide up. It just shows that your left ventricular function deteriorates with age, men and women as well. I like it because it shows that trained people also have a drop-off as well. Which is quite interesting because I expected them to somehow maintain it. So these are the drugs that are used commonly in ischemic heart disease, coronary disease, plus tricyclic antidepressants. And all of these make a difference to how you react in anaphylaxis. And the big thing are beta blockers, because they're being increasingly used for the management of ischemic heart disease, and that's been based on studies that go back sort of 20 years. But now in heart failure, and they're also used in hypertension and to control heart rate. So we've got lots of adult patients who are at risk of anaphylaxis who we have to negotiate with the cardiologists about, do they really need these beta blockers? And this is my current clinical quandary, because I thought I would share with I show you that I don't always know the answer, shocking though that may be. This is a chap who's come in with B venom anaphylaxis. He had 3 stings on his wrist. Immediately he felt warm and itchy. He thought it might be due to the fact that it was a warm day, but then he walked into the kitchen and collapsed. And the paramedics were called, very hypotensive, and eventually seen by me. And he's taking beta blockers. We're not entirely sure why. We can't get a straight answer out of the cardiologists. And I would like to give him adrenaline. Well, I've given him adrenaline. I would like it to work properly. But I'd like to give him immunotherapy, desensitization. But that is a contraindication, being on a beta blocker. So here we have somebody who has a poor heart, definition because he's got older. He's on a drug that may be helping his heart, but isn't helping his anaphylaxis, if he has it, and is stopping us from giving him the right sort of treatment. So in adults, things become more complicated really by what's going on around the disease as much as the disease itself. I've put this in because it's a really important thing to consider when people are prescribing adrenaline auto-injectors. The needle length for EpiPens and Jex pens is 1.43 centimetres, and I've just had a mental block about the one for MRA, 2.4 I think. Yes, Hazel's nodding for me, thank you. And you're putting it just above the knee anterolaterally. It's supposed to be intramuscular. Is it reaching muscle? And if you look at, this is American data, but let's say with allergy, where America goes, the UK follows, that 12% of children between 1 and 12, it wasn't reaching muscle. A third of them with the bigger adult device, it wasn't reaching muscle. And 42% of women. So, interestingly, in that study is that 20% of those had a normal BMI. So you can't just look at, do their BMI and say you'll be okay, because that's not necessarily the case. And this is Worcester data, and looking at the skin to muscle distance, and the red line on the horizontal is the 1.5, and you can see that there's a significant number of women who are above that 1.5 in that data. All the men in that study were below it. Spot the mistakes. So, this is Brad, who was on some sort of VSO type thing. He wrote a blog and said he was worried about going because he wasn't sure if anybody knew how to use an adrenaline auto-injector if he was unwell. And he said, but it's great because I've met Chloe and she can do it. You know, you don't put them in the deltoid and you don't need a neck brace to use it. But it's not as bad as this, which I found, and that's from a publication from last year. It's a Getty image, so perhaps the Anaphylaxis campaign would like to discuss with Getty whether they would like to remove it from their sort of gallery. So I talked briefly about pollen food allergy syndrome. Just go back to it. In the adult clinic, it's common, and what's interesting to me is that when I started doing allergy clinics in 1997, we used to get quite excited when we saw oral allergy syndrome. It was only first reported in 1982 by Peter Amlot. So, and now, you know, 2 or 3 of them in the morning quite commonly. It makes a huge difference to people's lives because they have to avoid all these fruits and vegetables. And the most psychiatric disease I have seen around allergy has been associated with oral allergy syndrome rather than anaphylaxis. I've seen anxiety around anaphylaxis, but excessive food avoidance around pollen food syndrome. And it's promoted as a trivial disease because it's not associated particularly with anaphylaxis. And yet it really affects patients' qualities of life. Allergic rhinitis increases as you get older. You see it in childhood, obviously, but the peak age of onset is the end of your second decade, so your late teens and your 30s. And it says that it gets better with age, but my mother, who will be 90 next year, would like to disagree with that. And it seems that that's not always the case. Let's do another case history. There's a 26-year-old personal trainer who had both springtime hay fever, correlating with the birch pollen season, and asthma. And he had typical pollen food syndrome symptoms with apples and pears. So he would eat a raw apple and pear, and he would get an itchy mouth. His nose would be a bit itchy or runny, and then the symptoms would be transient and would go within a few 30 minutes or so. And if he had apple that was cooked, so McDonald's apple pie, the hottest thing known to man, he'd be absolutely fine because the protein is denatured, there's nothing for the immune system to recognise, and the allergen has been removed. But what he had noticed that he was quite an obsessive trainer, and he was developing urticaria and wheeze immediately after using a new high-protein sports supplement. And he was sensitized to PR10, which is the soya protein that cross-reacts with birch pollen. And what he was doing was that the protein content of these supplements is huge. So he was having a huge dose of allergen compared with an apple, which was just giving him trivial symptoms. And when he was having these protein supplements, he was having problems. And I now have a confession to make, because I have a child who is allergic with pollen food syndrome and had 3 reactions to soya milk, which he would drink in a carton before it occurred to me that that's what was happening to him. And he wasn't getting, he was getting abdominal pain, and then on the 3rd occasion, when he had his soy milk, he had exercised, and he'd had some ibuprofen, he had a rash all over. And at that point I thought, do you know, I think I know what this is. So the cobbler's children's shoes are never mended. So just to think about patients with pollen food syndrome is you need to warn them about taking a high intake of their allergen, and that would include things like smoothies. So if you think about how much fruit goes into a smoothie, it's a massive protein load compared with just eating an apple, and patients can have anaphylaxis with those as well. I also think there's a problem with pollen food syndrome and protein pump inhibitors, because the normal thing that happens to the allergens in pollen food syndromes, they go into the acid in the stomach, they're destroyed and they stop causing problems. But if you're on a PPI, you have no acid production in your stomach. It's almost completely obliterated. And those PR10 proteins aren't destroyed, and then people have anaphylaxis. And we've had patients who, it seems to be particularly with hazelnuts, and they already have a relatively high protein content compared with an apple of these proteins, who have then had systemic reactions. But protein pump inhibitors, 43.4 million prescriptions for things that block acid in 2010. So when you see patients with pollen food syndrome, the patients need to be counselled about having a healthy diet, because you don't want them to avoid any fruits and vegetables they don't need to. Be cautious about their use of gastric acid blocking agents, and if they are using those, to be cautious about the quantity of allergen intake, and being moderate when they're eating things. So if somebody has anaphylaxis with milk, we say avoid milk. In pollen food syndrome, patients will still carry on eating things because they like them. And so they'll put up with some symptoms so they can have apples or peaches. So you have to be cautious. If you're still going to do that, you need to know that this is an issue. Drug allergy is a huge problem actually in secondary care. I don't remember the numbers. 1 million people get admitted to through NHS hospitals every year who say that they've got some sort of drug allergy, and 10% of the general population think they have penicillin allergy, but less than 10% of those actually do have penicillin allergy. But it makes a huge difference to how people are treated, because they may not be given the appropriate antibiotics, and penicillins offer advantages in terms of being specific for some infections and being well tolerated, whereas patients may end up getting broad spectrum antibiotics, which are less efficacious in treating the infection, and you have problems with having taken a broad spectrum antibiotic. So this was a 70-year-old chap who was in one of the Leicester hospitals. He had a post-operative wound which wasn't improving. When he'd come in, and this was elective surgery, he had said that he was penicillin allergic, and nobody had documented what had happened with penicillin at the time when he was pre-surgery. But now they had grown microbes on the wound that the microbiologist said, we would really like to give penicillin. Now the patient wasn't particularly well at that point, so he was unable to give much of a history. I'd had diarrhea taking penicillin, and so the two teams, the surgical team, in combination with the microbiologist, said, well, a bit of diarrhea with antibiotics, that's quite common. I don't think we should be worried about that. He really needs penicillin, let's give it to him. Unfortunately, the patient had anaphylaxis. And the story was, because they asked his wife, I'll read it out for you, Hazel, because you can't see. So he'd had penicillin on the first dose of a course of antibiotics, which is the classic time for penicillin allergy to present. He had collapsed on the bathroom floor with vomiting and diarrhea. So he hadn't had just a bit of diarrhea, and they'd had to call the paramedics. So that was a history of anaphylaxis. The risk factors for developing drug allergies, if you get IV administration rather than oral, prolonged courses, so extending into weeks, which is sometimes needed in infections, repeated courses over a short time frame, and the ones that we see in clinic, often it's things like dental infections, where they've had a bit of toothache, been given amoxicillin, and then given another course of amoxicillin, they've still got toothache, and then they have a fourth course and they have a reaction. Atopy, so having things like rhinitis and asthma, is a risk factor for severe reactions, but not for the allergy itself. But there are real challenges in drug allergy, and it is done by a few centres in large quantities, because it is a difficult thing to do. You can rarely, you can't take a history that excludes the allergy. There's a thing in all history taking called post-event bias. Patients remember what they think is important or what they think you need to know rather than what happened. So often they will remember that they'd had a peanut in the last week, because peanuts are important if you have an allergic reaction, but they may not remember that they had naproxen 45 minutes before the onset of their symptoms. Because they don't know. People don't know that naproxen is an issue. In vitro tests are safe in terms of drug allergy testing, but they're pretty rubbish, actually, because the only ones that are really well worked up and we have some idea of what they mean are for penicillins, neuromuscular blocking agents, and local anaesthetics. So in vitro tests are lovely and safe because it just involves taking a blood sample. In vivo tests, which require skin testing, are less safe. In fact, they can be dangerous, because even with negative skin tests for penicillins, you still have a risk that the patient will actually react to the oral challenge that you're going to give them amoxicillin. One of the things with drugs is that it's the drug metabolite that is the allergen. So you eat, you have your drug, there it is in one form, it goes through your liver and it's changed its shape. And the allergen that the patient is then reacting to is different from what was in the drug that was taken. And we don't know what that is, and we don't know how to test for it. So negative tests don't really mean very much. But who should get drug allergy testing? Because it's common and it's important to sort it out. Really, where the future use of that preparation is essential, and we occasionally see patients where they need that drug and that drug alone. If you can avoid that drug, then we don't need to do a confirmatory test to say, yes, it really was that. But if you really think that it's unlikely to have been the cause of previous symptoms and you'd like to use it, then do the testing. And that tends to be people with things like bronchiectasis. They've got lots of recurrent chest infections. They've got bugs that aren't responding to some antibiotics, the ones that they can take, and can they take penicillin? And we would do the testing there. Often because the history of drug reactions, particularly penicillin reactions, is vague. It may have happened in early childhood. A rash in a viral illness, you've been given an antibiotic for a viral illness, you've had a rash, is it due to the antibiotic, is it due to the viral illness? So there are an awful lot of people, and we know that from the statistics, 10% of the people who think that they're allergic to penicillin are allergic to penicillin, and it's finding those people and identifying them. But it's an enormous cost implication of sorting all this out. So most centres wouldn't routinely do it unless there were pressing reasons why you'd want to use the drug being tested. I've put this in because I can't do a presentation without something from the Mail on Sunday or the Daily Mail. And this, I'm just mentioning allergic contact dermatitis because this gets referred up to the adult clinic. These patients with awful dermatitis, and it'll be in the distribution of where they put on their sunblock or makeup, moisturiser, deodorants. And the Mail on Sunday's victory was about methyl isothiazinolone, which is a preservative which you find in lots of products. And lots of people are sensitised to it. And sensitisation rates for these agents increases as you get older. And it makes people miserable because it's unpleasant, and it's sore, and it's burning, and they don't know why it's happening. And it's everywhere. I've said it once. I can't say it twice. MIT. If you think that food labelling has small font for the ingredients, shampoos is even smaller. I was told by a patient what they do is they take a photograph on their phone and then they expand it up. I think one of the major problems for adult allergy is access to care. The waiting list in Leicester, if you want to see me, as a new is mid-November, and the challenge waiting list is approaching 2 years, and we're not unique in this. Pediatrics, I think, have got it sorted because they put, I would say that, wouldn't I, because I'm surrounded by them, but they have put in place training people as part of their training is open to more specialist trainees in paediatrics, and in allergy, and I'm chair of the training committee at the moment. We haven't had the expansion of training numbers in allergy, and there are shortfalls in trainees coming through into consultant posts. So there are empty consultant posts, and there are centres that don't advertise because they know there isn't anybody who would go to them. And this is one of the big challenges, because the perception is, for adults, that allergic disease doesn't happen in adult life, but it does. And it makes people's lives very difficult. We're becoming an NHS that has to think about what it's going to pay for, and I'm worried that quality of life services, which essentially is what allergy is about, are really going to suffer, because we're obsessed with acute care and not how people live their lives from day to day. And I came across a new concept in the weekend, which was, let's not think about lifespan, think about health span. And at the moment, a health span is being affected by people not seeing specialists. And I know that seeing an allergist makes a difference, or any centre that does allergy care, makes a difference to people's quality of life, positively. These are things that influence health, and I suppose the solutions are, can we sort out in our allergy consultations all this aspect around allergic disease. So that's quite difficult in services that are straining at the seams to see patients. Nutritional, I would just say that my service doesn't work without a dietitian. I mean, in fact, virtually I'm redundant in quite a lot of things. And we're not supporting allergy services as they go on. In summary, but I meant to say this beforehand, so now that I've remembered it, we talk about hen's egg allergy because duck egg allergy exists, and it's very popular in people who have, I think it was in the Waitrose magazine or something, because it seems to be, you can buy them in Waitrose, duck eggs, and we've had patients who are absolutely fine with hen's eggs, but not with duck eggs. I just wanted to make that point. And that is a Solihull phenomenon, I feel, or Hampstead, or wherever. So in summary, actually what allergic disease is isn't terribly different between adults and children. Adults, the epidemiology is different. Adults are more likely to have drug and venom allergy and secondary food allergy, and there's a lot of morbidity associated with secondary food allergy, whereas I think people are concerned about the mortality associated with primary food allergy. Other conditions make a difference to whether people, how people cope with anaphylaxis, or how they get, what symptoms they get. Adults live inherently more risky existences than children. I have learned as children grow up. And as you give them freedom, it's quite important for children to have freedom so that they learn to make decisions and be safe rather than not make decisions and then not know how to be safe. And that's what transition care is all about. We're beginning to see, and you saw the slides flashing past in Nick's presentation, the prevention of allergic disease in childhood, and it's becoming a reality. In adulthood, I don't know. We await to see.
Thanks very much, Alex. Time for one quick question, maybe before we break for lunch. Oh, Rebecca, you've already had one, Hazel. Rebecca. No, Rebecca.
You're rationing.
Okay. Thank you. It is only a quick one as well. It's always struck me that there is very little research done on the older allergic group. So adults, but also older adults, so in their 60s and 70s. So adults who have allergy, given that we're an ageing population and we're expected to work longer, are you seeing any of those adults outgrowing any of their allergy, or is that something that is then going to be with them for the rest of their lives? And are we then going to be seeing in a few years' time a huge number of older people trying to manage their allergies as they get older and start to suffer from things like dementia and not know what they're supposed to be avoiding in terms of foods, etc.?
So first off, in contrast to paediatrics, we don't follow people up over years. So we don't look at people prospectively. But when you see patients who are presenting, and they've had an allergic reaction, they've been referred in, and they say, oh, this has been a problem for 15, 20 years, and it's just that it's got bad. And so I don't think it goes away, and I think that is a real issue that we haven't really thought about. And the dementia thing really worries me, because the depression thing really influences people's safety.
Okay, thank you very much. So let's thank all four speakers this morning for an excellent presentation.